Thank you for the opportunity to talk today. Eugenia had asked me to speak a little bit on some basics with physical function as well, and then I'm going to delve into some aspects of what it means, what we should do with it, and how we define it. So to start with, I think a lot of times we hear various terms that get thrown around, and sometimes it's hard to know that we're all talking about the same thing. So I wanted to start with just some definitions of how we might define physical function impairment. So to start, I think we can look at a specific impairment. So this might be something that we diagnose on physical exam or by a lab test or by some sort of imaging or x-ray. An example might be someone that has hearing impairment that we've diagnosed on an audiology exam. If that impairment isn't treated or progresses, it could lead to an activity limitation. So someone's therefore not able to do something because of this impairment. An example of this might be if someone has severe osteoarthritis and therefore they have slow gait speed. And these are oftentimes defined by performance-based measures, so gait speed, time to up and go, a 6-minute walk distance, or by self-report. So somebody may have some difficulty that they just tell you they have. If untreated or not dealt with, these could lead to a disability. Importantly, a disability is more of a social issue. So this is that there's a lack of resource to help define this or help treat this situation. So for example, that person that has hearing impairment, if they don't have insurance coverage or a way to get hearing aids, they may have significant disability from their hearing impairment. Whereas if they can get hearing aids, they may not have any difficulty with this. Another example might be if someone has severe problems going up and down stairs, they may have a lot of limitation in their daily activity. However, if they live in a home where there aren't any stairs, then it may not be an issue at all. Importantly, as you can see from this figure, frailty is kind of a separate aspect. It's probably related to functional activity limitations and related to disability, but it implies more of a vulnerability, and it's a separate issue that may or may not be directly related to disability. And when we talk about frailty, there's two common ways that we tend to define frailty, which many of you are probably familiar with. The first one is the Fried Frailty Phenotype, and the other way is the Rockwood Frailty Index. The Fried Frailty phenotype represents a vulnerability, and it's often defined by 3 or more impairments in the five variables of slow gait, weak grip, low activity, fatigue, and weight loss. There's 5 points total, and so it's kind of difficult to change someone out of frailty once they go in part because of the definition. It does require some equipment. One thing would be a dynamometer, which can be a bit of a pain and not typically something found in a clinical setting. And there's also a lot of overlap with depression. A lot of these measures like low activity, fatigue, and weight loss can overlap significantly with depression. So sometimes we don't know if we're picking up severe depression or actually a vulnerability as defined by frailty. The Frailty Index, on the other hand, is an accumulation of deficits. So the more problems that someone has wrong, the more likely are that they're frail and they may end up in the hospital with a prolonged hospital stay. This was initially developed using an index of 70 different variables. Ken Rockwood has gradually trimmed this down to about 30 or 20 variables, but it still can be somewhat cumbersome to try to put this together. And the variables have specific characteristics, such as they have to be associated with health status. They tend to increase with age, but don't become oversaturated. So for example, someone that has presbyopia requires glasses as they get older wouldn't necessarily mark a vulnerability, so that wouldn't be a variable, whereas other variables might be included. Importantly, these variables also must cover a range of different symptoms, and if it is repeated over time, then the same index needs to be used each time. There is a similar index that's been established in HIV that doesn't necessarily meet all of these requirements, but kind of gets at this idea of the number of laboratory values that someone has wrong, and that's called the Veterans Aging Cohort Index, or the VAX Index. The nice thing about the Frailty Index is it doesn't have to be done in real time. You can go back and derive a score from existing chart reviews. So when we do these frailty indices or different measures of physical function, we indeed see that physical function impairment appears to be more pronounced in people living with HIV. This was one of the first studies that found this from Kristine Erlandson looking at men with HIV. And you can see in the red line that they have a lower VO2 peak or measure of exercise endurance compared to men without HIV. And similarly, we found in the multi-center AIDS cohort study that men aging with HIV have a faster decline in gait speed with age that seems to separate at about age 50, as shown in the red line, compared to the uninfected control shown in the blue line. We also see that frailty tends to occur at an earlier stage in people living with HIV. And you can see again, there's a pointer work, multi-center AIDS cohort study that starting at about age 50, there's a separation with increasing frailty in the men with HIV shown in the filled in circles compared to the open circles that are men without HIV. And the occurrence of frailty tends to vary quite a bit based on the different study population. And several studies have looked at the prevalence of frailty ranges anywhere from about 5% to about 28%. That tends to be most dependent on if someone's on antiretroviral therapy, how old they are, and other characteristics of the cohort. So what factors contribute to frailty? And this is one of the things that first sparked my interest in frailty, is how similar this proposed mechanism of frailty in people without HIV is to what we see in HIV. So many of these factors are things that we've talked about in the last couple of days, such as molecular disease triggers like oxidative stress, telomere shortening, DNA damage, and cell senescence. A lot of these are thought to be the primary contributors to frailty in the general population without HIV. We also see that high levels of inflammation, sarcopenia, osteopenia, all factors that can associate with frailty in the general population. And indeed, we've shown that many of these factors are associated with frailty in people with HIV, and probably to a greater extent compared to the uninfected controls. We've also looked at some additional factors that are associated with frailty, clinical factors that we might see when we see patients in clinic. We did this in the HALO cohort, which is a cohort of people age 40 and older who are on antiretroviral therapy and followed through the AIDS Clinical Trials Network. We looked both at factors associated with frailty as well as factors associated with that simple measure of just gait speed, so 4-meter walk from me to about over there, so short walk. And you can see that frailty and gait speed were associated with many social factors like education and insurance, as well as some race, ethnicity, and age, not surprising. We also saw an association with several modifiable risk factors like smoking, low activity, and obesity. We did see some association with antiretroviral therapy, namely that prior initial randomized NNRTI, so specifically Systiva for this population, was associated with increased development of frailty, and then prior D4T or DDI exposure was associated with slow gait. We also saw a protective effect of integrase inhibitor. Somewhat surprisingly, although we saw an association with neurocognitive impairment in both slow gait and frailty, frailty in this cohort was not primarily driven by comorbidities. So what are the clinical implications? We measure frailty in clinic, but what does it really mean, and what can we tell our patients should we find frailty? Well, again, in the HALO cohort, we looked at the clinical implications of having frailty, and at any given time point, someone who is frail or had slow gait speed had an increased risk of developing cardiovascular disease or diabetes, even after adjusting for additional risk factors for cardiovascular disease or diabetes. And this suggests that frailty may be an additional risk factor that might help perhaps better inform some of our cardiovascular risk prediction scores. We also saw that somebody that developed frailty over 2 years of follow-up had a 4-fold increase in their risk for mortality. So when we see someone with frailty, they're at high risk of mortality, can help us kind of form some more decisions about their care. This has also been shown in the ALIVE cohort, which is a cohort of IV drug users in Baltimore. And we saw that the lowest survival, shown in that kind of yellowish line, was in people that had both HIV and frailty in comparison to someone who had HIV or frailty alone. This is a busy slide. I'm just going to skim over it quickly. This is basically to say that there's a lot of different tests that we can do in clinic, and there's pros and cons to all of them. I think we're most familiar probably with the frailty phenotype and the frailty index. Single measures of just gait speed, as we talked about a bit in the morning session, might be a great measure that's really easy that you don't need extra equipment to do. One of my favorites is actually the chair rise time. So it's how quickly can someone rise up from a chair 5 times or even 10 times. You can do it after you check a blood pressure on a patient. It doesn't require anything other than a chair. It's a great measure of lower extremity strength. and also on the components of the short physical performance battery probably has the most abnormalities, so we might pick up more impairment on this test that might help stratify patients. So when we see patients with frailty in clinic and we find frailty, what do we actually do with it? We can tell patients they're frail and they may get worried about it, so how might this inform our clinical care? Well, I think there's a lot to be learned about this, but some things that we can do with frailty are to help us direct where our goals for our patients might be. So if someone's frail and they have a high risk of dying in the next 5 years, is it really worth that patient's time, energy, and risk to spend money and their time screening for cancers that aren't necessarily going to prolong their life, such as breast cancer or prostate cancer? It also might help identify patients, particularly in resource-limited settings, that might benefit more from referrals to geriatric care or trying to reach out and get some of those social services. And it also may help us, particularly with our older patients, to define care frequency, the frequency of visits. So if we have someone that's frail, perhaps they need to be seen much more commonly, whereas those patients that aren't frail could maybe have visits every 6 months to a year. The other area that I don't think we've looked at that much, but I think would be really interesting and important, is can we use some of these measures of physical function or frailty as endpoints for clinical trials? So a lot of our clinical trials focus on things like inflammatory biomarkers that might not be as important or relevant to patients. But what if we can study the impact of some of these factors, such as statins, on how someone actually does in the real world? We have a small study as part of the Reprieve study that was mentioned earlier this morning, looking at statins, where we're actually looking at whether or not muscle function changes by the chair rise time with the addition of statins. And I think this could ideally be implemented in more studies where we can actually see what the impact of some of these anti-inflammatory therapies are on things like physical function. So most importantly, I think one of the reasons that we need to identify some of these physical function impairments are that we can intervene. And you can see in the top line the trajectory of normal aging. So someone goes through most of their life, they have a high level of function, it starts to decline a bit as they get older, and then maybe into their last 5 to 10 years of life, they dip down and have a decline, and maybe have some frailty that they suffer in the few years before they die. In someone who has accelerated aging, as has been proposed for HIV, someone might have a very rapid decline in their trajectory of normal function. They dip down into frailty in their midlife, maybe even in their 50s, and then end up spending a good portion of their life disabled. And as you can see, when someone gets down in this disability range, it's much harder to try to bring them up to that normal aging trajectory of function. And if we can intervene at a much earlier stage, when perhaps someone has a slight slowing in their gait speed but are far from frail, it's much easier to shift that curve up to the normal aging trajectory and try to preserve their function for the majority of their life. And so there are some great pill options that we can use to try to treat frailty and these physical function impairments. For example, this physician tells his patient, to treat your high blood pressure, diabetes, hyperlipidemia, and osteoporosis, take this new pill every day. Take it out for a jog, and then take it to the gym, and then take it for a bike ride. Nobody's laughing. I thought it was funny. Thank you for laughing. So I think this really highlights the importance of physical activity as one of the mainstays of trying to preserve physical function with aging. And exercise has really been the most consistent intervention to try to preserve physical function and to try to reverse that frailty curve. So I wanted to talk a little bit more about physical activity. And higher levels of physical activity have been shown in multiple studies, either interventions of exercise or just cross-sectional studies of self-reported activity, to improve many of these endpoints that we've discussed throughout the conference. So we see a decrease in inflammation, an improvement in mitochondrial function, improvement in immune function, improvement in body composition, improvement in cardiovascular risk factors, increase in strength, improvement in mood, improvement in fatigue and depression, and multiple other systems that exercise has been shown to improve. But there's also a lot of unique factors that may influence the ability of people with HIV to exercise or their desire to exercise. We did some focus group studies as part of my work at Colorado and found that concerns about stigma, particularly in people that go to the gym, their body appearance may impact their ability or their desire to go to the gym. There's a sense of disability. A lot of patients were told 20 years ago that they were never going to live for this long, and so they just have a sense that they don't need to exercise or that they are disabled now. There's a lot of other challenges that distract from making physical activity a priority. If people are searching for food and housing or have issues with substance abuse, then physical activity gets put as a lower priority. Certainly the environment that someone lives in can be, if there's safety issues, they may not have the desire to go out and exercise, and they may have a lack of financial barriers to go out and find a safe place to exercise. There's also a lot of physical issues and physiologic issues why someone might not be able to exercise or might not feel that they have the same response to exercise. Mitochondrial impairment, issues with peripheral neuropathy, low testosterone are all factors in HIV that may impact someone's ability to exercise and their response to exercise. And we do have several prior studies that have focused on measures of muscle, and these are primarily studies done in younger populations and mostly focused on traditional exercises like cardiovascular treadmill exercise and resistance exercise. And many of these have been supervised exercise programs for a couple times a week and have shown nice improvements in muscle strength and function. But our goal and question was how much exercise is enough, and does that response to exercise differ in people that have HIV? And so this was the basis of a study that we recently completed, and as part of this study we enrolled sedentary people living with HIV, so they weren't already exercising, and uninfected controls that were between ages 50 to 75. We had them come in for 3 weeks of a supervised 3 times a week for a supervised exercise intervention for 6 months. The participants started at about 15 to 20 minutes on the treadmill and gradually increased that to 50 minutes by the end of the exercise period. And they also had 4 different weightlifting exercises, the leg press, bench press, lateral pull down, and then 1 exercise that we rotated. And as part of this study, we had everyone start for the first 12 weeks in a moderate intensity of exercise, and then after 12 weeks, we randomized them to advance to a high intensity exercise or continue with that same moderate intensity exercise for an additional 12 weeks. This shows the breakdown of the participant flow. So we had about 69 participants that actually started exercise, 59 completed the first 12 weeks, and then we randomized half to continue to moderate intensity and half to advance to high intensity. 3 more dropped out after that midway point. We had 27 moderate and 29 high intensity exercisers finish the study. So this shows kind of the summary of our initial results. Down on the x-axis, you can see the percent improvement between 0 to 12 weeks that's shown in the darker color bar, and then the percent from 13 to 24 weeks that are shown in the lighter color bar, and then the measurements on several different functional measures, starting with simple things like the chair stand and 400-meter walk, and then into some strength measures such as bench press and leg press, and then our VO2 max, which is a measure of exercise endurance. Those living with HIV are shown in the red bar, and then the HIV uninfected controls are shown in the black bar. So to start, you can, just taking a glance at this, you can see that most of the improvements that people had were really in the first 12 weeks of exercise, shown in that darker color bar. And then overall, people had about 10 to up to 45% improvement on these measures just by exercise over the 24 weeks. And those results seem to be pretty similar, actually, regardless of HIV status. We did see some important differences in that the people with HIV actually had more improvement in their 400-meter walk time, their ability to climb a flight of stairs, and their VO2 max, measure of exercise endurance. Our other question was, does that intensity of exercise matter when you have HIV? Our concern was that some studies have shown that people that exercise at a higher intensity exercise actually do worse, particularly if they have underlying inflammation. But here we found the people living with HIV that were randomized to high intensity are kind of in that pinkish color, and then the moderate intensity in the red color. And we actually found that people living with HIV that were randomized to high intensity exercise had significantly greater improvements in their strength by bench press, leg press, and lateral pull down, suggesting that extra emphasis on muscle actually led to really nice improvements in people living with HIV more than our uninfected controls. The study didn't have a functional requirement when people came in. We actually didn't have anyone that was frail enroll. I think some of that was the fear of doing exercise for 6 months may have frightened some more frail individuals away. But we did have quite a few pre-frail, and we saw a nice decline in the proportion of pre-frail patients shown in the reddish and greenish colors over the 24 weeks of the intervention. So other types of activity have also been shown to result in some physical function improvements. There was a study presented at the IAS meeting last year looking at Tai Chi, and this was a study that enrolled people that were 50 or older that had substance abuse and chronic pain, and randomized them to Tai Chi with cognitive behavioral therapy and text messaging, and saw a significant improvement in their short physical performance battery scores from about 8.2 to 10.7, which is quite a nice improvement that they did not see in the other arms. And then other types of exercise interventions that have been looked at, not at all focused on the older population. There's been a little bit of research with yoga and HIV that has shown some improvement in blood pressure, substance abuse, and quality of life. Really no focus at all on physical function. And so lastly, I just wanted to touch briefly on if there's other ways that we can enhance this physical exercise response. And one thing that we've looked a little bit at is Tessa Marilyn. So Tessa Marilyn is a drug approved to decrease visceral adipose tissue in people living with HIV. And we know that people living with HIV actually have more fat within their muscle as they get older, as was presented in the sarcopenia talk yesterday. We went back and looked at the prior studies of Tessa Marilyn and found that people that were randomized to Tessa Marilyn and responded to it actually had a significant decrease in their intramuscular fat. The study unfortunately didn't collect any measures of function, but I think this suggests that Tessa Marilyn might be an additive to exercise that may help further improve function. And then lastly, there's some studies in older obese adults without HIV that suggest that weight loss through a diet intervention in addition to exercise probably has significantly greater improvement on muscle function. This was a landmark study presented in the New England Journal of Medicine back in 2011, and you can see that the group randomized to both diet and exercise had the most significant gains in 2 different physical function markers compared to those that just had diet or exercise. There's a lot of unanswered questions regarding exercise and HIV, particularly to improve physical function. What type of exercise may have the greatest benefits? I think the most important factor here is the type of exercise that has the best benefits are probably the ones that our patients do, and trying to work with them to figure out what exercise they enjoy the most and what they'll actually stick with and contribute or participate in over the long term. We don't know a lot about potential benefits or harms of therapies added to exercise. I think there's some interesting microbiome aspects that could be investigated here, as well as anti-inflammatory therapy before or after exercise, if that might boost some of those responses. And then I think the most important question is how can we engage and keep people exercising throughout their lifespan to prevent some of these issues in the long term. So in summary, functional limitations and frailty can provide a window into our patients' vulnerability. It may help guide clinical decision-making, and it might serve as a clinically relevant endpoint for trials. Intervention should ideally focus on early interventions or early impairments that occur in midlife before an individual becomes frail or more severely disabled. And exercise is a safe, effective option to improve physical function in older adults with HIV. And probably that higher intensity exercise will result in the most improvement in muscle. And we certainly need additional interventions to help improve our sustainability and increase exercise response. Just briefly mentioned, thank you to our study participants that dedicated 6 months of their lives to come in 3 times a week and exercise, my study team, and then grant sources. And I think I had a thank you there. Thank you from Colorado that has beautiful mountains and wonderful weather. So thank you very much.